Welcome, folks. This is House Corrections and Institutions. It is Wednesday, February 12th. It's a little bit after 11 o'clock, and we're going to be working on one of the bills that has been sent to our committee. It's House Bill 32. And we have a couple of folks from DOC's world, and we have Avia, I can never pronounce your name, Avia Teva, who's the Executive Director of Health, Wellness, and Engagement for the Department of Corrections, and Dr. Euliger, I got it, Euliger, who is the Medical Director for WellPath. So both of you could come on up, and I don't know which one of you would like to start first, but I'd like you to focus in on H32 and how you see it playing out in your world. So I would like to go first. And whoever does, please introduce yourself for the record.
So Dr. James Euliger, Medical Director of WellPath for the Vermont DSE.
And I'm Aviva Teva, the Executive Director of Health, Wellness, and Engagement for DOC. Thanks for having us back.
Thank you.
So I think we wanted to start by saying we strongly support the legislative intent of the bill as written. And in fact,
The intent.
the legislative intent, which, as the way I understand it, is creating parity between community access to MOUD for incarcerated individuals. And that's, in fact, why I came to work for WellPath. I originally hired a patient specialist, not the medical director, and that was my goal. I'm concerned about that the bill as written and as I understand it actually might create the opposite effect. And I'd like to kind of spell out why. We actually do have, and forgive me, I don't know the exact legal structure, but we do have memorandums of understanding with several of our opiate treatment programs for methadone. And so that's how we currently, because we're not an opiate treatment program federally registered, we do not provide methadone. Though our patients do receive methadone through the opiate treatment programs.
So say that again. You have an MOU for your opioid treatment program
For methadone.
with the hub,
With the hubs.
with those local hubs near the facility?
Yeah, we try and make them with the local hubs. Not all of the local hubs are always interested, which is another one of the challenges. And one of my colleagues who's our director of recovery services could speak to the nuance of that, but I know we've had a challenge at Southern State, for example, having the local hub. There are some legal challenges with their parent organization and the DEA that is more nuanced than I could speak to on record. Yes, sir.
Just at a very basic level. So do they come to you or do you have to bring the inmate to them?
So the challenge is neither. So this is why I'm really concerned about the bill as written, is that they may see the individual once at the beginning, either in person or by telehealth, and then any adjustments in therapy are really made with all asynchronous communication. So
Say that again.
So they may see the individual. So if we have a person who arrives on methadone in the facility or is in the facility and needs to go from Suboxone or Subutex to methadone, that evaluation, their ability to evaluate the patient, and with all due respect to our fantastic, we have the best hub and spoke system in the world. So this is not a criticism, it's just a logistics, is their ability to evaluate that patient. So sometimes we may send them there, or there might be a telephonic audiovisual communication. They determine the appropriate dose or to continue the dose, whatever it may be. And then that's often the extent of their ability to do an evaluation for the patient. It's very different than when we have somebody when I see somebody in withdrawal in our facility, we can get them on Subutex, on buprenorphine right away. We need to do better at doing that, by the way. And I'm well aware that and this is a national problem, to be honest with you. In some ways, we're leading the way of the access that we provide to MOUD within our facilities. That being said, we are not at the point that I would like to be, where as soon as somebody's far enough in withdrawal that it's clear that they need MUUD, that they get that medicine straight away. I have spent the last year plus at WellPath putting a lot of work into how we would realize that. If we had to undo all that and strike a new, have a new way of making this happen, that would be a big setback in my mind. So when we see people suffering, and for those people who go on methadone from our hubs currently, and they're doing well, and they're doing well, fine. And again, the hubs are fantastic partners. So this is a systems issue. But when somebody isn't doing well, it's what do we do? And they're on buprenorphine. We sit down. Hey, I heard you diverted some of your bupe. What's going on? What do you need? Do you need a higher dose? Do you need a lower dose? Do we need some drug screening? What are we going to do? That type of interaction that we sit down across from our patient and have. Right now, having an external clinic to be having the authority over this isn't that would be very different. It's too bad Mr. Fullen isn't here, and I absolutely cannot speak on his behalf, but I'm concerned about their ability to have the staffing levels to be able to deliver on that.
This is a crux of the matter that I want to get into for this. So when a person becomes incarcerated, do they sever their relationship with their primary provider? Does the primary provider, while that person is incarcerated, have any say over the delivery of healthcare for that person while they're incarcerated? Are they still a patient of that primary provider on the outside?
Now, in a legal sense or a practical sense?
Both.
So I can't speak to the legal sense. Practically speaking, I can speak for my psychiatric colleague, Dr. Richards, who's our psych medical director. Both of us have been encouraging our providers, because we often see our
Providers being the folks within the incarcerative setting. Well,
yes, that's correct. When they come into conundrums, the question is, well, have you talked to their community provider? What's going on? Often these are people who've taken care of them and many of our people, sometimes they don't have a community provider, but when they do, what a source of information. So when as we improve our processes, which we're doing, I hope we continue more and more to reach out to community providers.
so is there a legal deterrent? And this is something, Isaac, maybe you can follow up. Legally, is that allowed? What, for the person who's incarcerated, not a detainee who's there for a few days, but even a detainee who's there for 3 years and a sentenced person, legally, can they still be under a provider in the community? Can they be under their care?
So that's a different question, because in the example I gave, we're using them as a source of information as a consultant. In terms of, can they be under the primary care provider's care? That is.
That's what we need to know as a committee before we move forward, because when a person becomes incarcerated, they lose all their insurance. And as a primary care provider, able to give them any health care while they're incarcerated, because that primary care provider on the outside probably won't get paid for.
It might be why it doesn't come up very often. I think also it would sort of depend what we mean by providing care. So I don't think anything would prevent someone from being kind of engaged with someone on the outside who had been providing them care.
Or in a consulting way.
Yeah, communication, but that the actual kind of medical staff that will be available and will be in person would be the WellPath staff.
And who would be able to prescribe, I'm not even thinking MOUD, but just general blood pressure, cholesterol? Who is that primary care provider on the outside? Would they be able to prescribe medication for a person who is incarcerated?
I can't speak to the legal aspects. I would speak medically that it's really when there's any primary care relationship. And Vermont, honestly, among states comes closest to this. The primary care provider is captain of the ship. And so
Primary care provider what?
he's captain of the ship.
Okay.
So, there's a the cardiologist wants them to have less fluid on their body. The kidney doctor wants them to have more fluid on the body. It all comes down to the primary care provider. It is important to know who's, I'm going to say this very gently, like who's in charge, not from a bravado standpoint, but from a who's the ultimate decision maker about the person's care. And that is an important question to answer.
And who is if they're incarcerated?
Right now, if they're incarcerated, it's our WellPath team.
Okay.
That practically speaking, again, I'm not speaking to the legal aspects. The other thing I would offer to that would be that the practice of medicine within corrections is to some degree a specialty in and of itself. I believe the American Board of Medical Specialties is looking at adding corrections medicine as a actual specialty. So not that we couldn't have a community provider who would provide excellent care, and I can imagine a place where that would be, but there are some things that they're not gonna, some aspects and nuance to providing care within the facility that we all had to learn when we came into corrections.
Kevin, did you have something before I interrupted?
No, I got my answer. Thank you.
All right.
I'm still working on. And I mean, right, we're already asking you questions and you got through maybe a third of what your notes are. So maybe, look, can I just throw this out there and then you decide whether or not you want to answer now or if it's going to come up or something like that. These are my big questions. And they've kind of been, that's why I'm hesitating whether or not I want to bring them in now. I'm worried that about what happens to continuity here. This is why I think codifying some of this stuff is important at the end of a WellPath contract, and that doesn't get renewed. I'm worried that if a WellPath contract doesn't get renewed, you're gone, right? As somebody who is trying to infuse some continuity and changes to this. Those are significant worries for me, which is why I think codifying this is important. I'm also curious about how you feel, both of you. Maybe I want your answer on this one more than his. How easy is it to be a WellPath provider in Vermont, right? When you've described Vermont's hub and spoke model as world leading, right? Does WellPath let you do that? And what happens, right? So we're trying to make sure that is in place, right? We live in a state where our hub and spoke model is incredibly well intended. I want to know how much WellPath is in the way of that, or if you have a long leash. And then again, I'm sorry, I'm firing this all at you. I will want to know too, your thoughts on the federal certification components of this bill and where you think that would ultimately lead as far as that would allow us to do this in-house, right? Building to a program that allows us to do this in-house. We don't have to have the MOUs anymore because we're staffed. And right now, I think WellPath would be a hurdle for that. So those are the good things in this bill that I want to really bring front and center. I'm skeptical, incredibly skeptical of using private WellPath for profit. That I don't like that. I've said this publicly. I'm encouraged by what I hear from you both. Thankful, grateful that you're in that position. I'm worried about what happens 2 years from now, 3 years from now, when you may no longer want to work for WellPath. We don't want to recontract with WellPath. So I want to get a lot of this codified. That's why I love this bill. That's a lot. I'm sorry.
No,
that was a
don't
word
be
on
sorry.
it, and yeah.
I asked myself some of those same questions. I think they're great ones. Do you want to either something? Yeah.
Sure. I mean, this isn't specific to MOUD, but I will share again that from what I have seen in the short time that I've been with DOC, the barriers to better care, again, from my perspective, are not related to WellPath, nor to WellPath being private. They're related to providing really high quality care and corrections. And Dr. Yurger made a related point. There's a lot of operational and logistical challenges because people are incarcerated because of what that means day to day to providing care that we as systems have to figure out how to navigate. And I think part of why, some of our concerns about the way the bill is written are that it would be hard to expect another set of entities to actually be able to do that effectively. And so one of our concerns is that, the opposite thing would occur from what we think the intent is, which would that be that the care would be more inconsistent because it would depend on the kind of specific community-based partner and their ability to navigate these obstacles that, to WellPath's credit, because this is what they do, they're very understanding of and familiar with some of these, again, there's operational day-to-day kind of, how do you provide high quality healthcare and corrections? So, that's really kind of general. And like Dr. Uliger said, I share some of the kind of philosophical questions absolutely about a private provider. I think the other thing just to highlight at that highest kind of general level is the way that our contract is structured. WellPath doesn't have an incentive to provide worse care. So in terms of how you can make sure that commitment of the DOC is maintained, to structure our contract with whomever is providing our care such that there is no incentive to provide worse quality care. That I would be curious to think through what that looks like. But currently, the way we partner with WellPath, they don't make money if they provide a lower level of care to people in custody. And kind of the opposite, there are ways that they can make more money if they meet certain health metrics. So
Which they're not meeting right now.
they meet some of them. It's complicated because some of them have to do with the care itself, and often it has to do with the way that it's tracked in our data system, which doesn't quite fully meet our needs yet. So we're happy to share more about that. And it does require more explanation because you see on paper a certain percentage, and then we have to sort of explain the numerator and the denominator. But I don't know if that's helpful. That's what comes to mind at the most general level. I think, we feel currently like we're in a very good position to work with WellPath to kind of provide high quality, in this case, MOUD. And one of the ways that is true is that it's the same system across all facilities because it's the same entity that is providing those services. So again, instead of having to rely on kind of the partner in a particular geographic area and their staffing and their nimbleness, et cetera, we're able to have consistency in our standards and our expectations and our practices across all 6 facilities, which I think is we don't want to overlook that existing kind of status quo.
Kevin?
This is dangerous because my understanding of what I've heard is that WellPath is the primary decider for an incarcerated person as to what they need.
Well, it's
If there's a conflict,
yeah. So there's actually an important, I'm going to sound like I'm nitpicking, but it's not. It's a very important discretion. It's the independent medical judgment of our providers.
but within WellPath. Right. And I thought what we were aiming for with H32 was to make sure that good level of care that is going on before they are released continues when they get out into the community. Is that not what we're trying to do?
Both.
Part of it too.
Okay,
It's both. It's while they're incarcerated and
Okay, well,
also
okay.
reentry.
All right.
And reentry.
right.
Please,
So,
sorry.
and I also think I heard you say that in practice, WellPath does not consult with the community providers because there's no insurance, there's no incentive for them to want to participate. No, okay.
We didn't mean
I
to
misunderstood
suggest
that.
that.
No, I
Said
think
that.
I'm trying to improve the habit of our providers at the ground level in sometimes if somebody's blood pressure is well controlled and their diabetes, there's, that there may or may not be a need to consult, but we definitely have, there's many things when people come into the facility of, are we verifying their meds, all those things, et cetera. What I was referring to is when there's a diagnostic or therapeutic dilemma, I would love please pick up the phone and call their community provider. That is the right thing to do. And even more so for our psychiatric patients. And again, I'm speaking on behalf of my psychiatric colleague, but I've heard her say it dozens of times. Please pick up the phone. It's the right thing to do.
But by you reiterating it, it says it's not happening enough.
Oh, yes. And the whole, there's a journey of quality, I will say. And, you know, you were making when you were, we were talking about meeting the pay for performance and quality metrics and whatnot. And this is actually, I'm going to ask a question that I should, and I don't know the answer to. Is how much of that is WellPath versus how much of that is the fact that we've had a new contract every couple of years? And I want to be clear, it is not my goal when I get up every morning and when I retire at the end of it's that I take good care. I'm not trying to defend either a private or a state system. But with that level of operational change, it is hard to sustain improvement in a quality journey. And that's not meant for self-preservation in the least. That's just a truth. And so I don't know how many of those challenging metrics that I look at all the time and I shake my fist at, how many of them are really a WellPath issue or just this is what it's been.
And I think just a couple things to add, and I agree that the kind of turnover of whomever is responsible as an entity for providing the care poses a lot of challenges, and the period of time it takes to transition from one to the other is significant and worth us really thinking through the costs of that just administrative process and what we could do about it. A couple of things though, when we're thinking about kind of community-based healthcare providers and whomever someone might have been seeing before they were incarcerated. I think it's one thing for us to think about how we can make sure that we are connecting as much as possible with those providers and kind of having continuity of care. And when someone is in custody, we as a DOC are responsible for providing their healthcare. So we can't just say, if you have a good doctor in the community, let's hope we can get you a telehealth appointment and, we'll do what we can over here. Like, we provide full, comprehensive A to Z, to the best of our ability, health services for every single person in custody. And I think that's more thorough than if we were to be relying on whomever someone might have had access to in the community. So again, not that we shouldn't kind of integrate as much as possible, but I do think it's important that there is an entity, again, private or not, different question, but somebody is responsible for the full comprehensive health care of every single person while they're in custody, the second they get there until the second that they leave. And that kind of thinking about the health care providers in the community is a different question from who is it that is providing that A to Z, moment you get there and a moment you leave, comprehensive health services.
Can I just clarify? I
Yeah.
think it's important that we have to start thinking about this not ending at the point when they leave, when they depart.
Yes,
One of the
agreed.
big parts of this bill is the seamless transition out and setting them up for success. So
Agreed.
another thing that framework, let's just remember that this isn't from point A to B, it's from point A to B plus.
Yeah, I appreciate that.
So let's keep that as an important topic too, because there's components of this bill that are very deliberate in structuring that seamless transition.
I completely agree. And I appreciate the reframing. And I didn't mean to suggest that we
Right.
don't care what happens after. I meant more, we can't mandate other people to do certain things in our system if we aren't responsible for what happens in that window. Now, how we can be responsible for what happens after, I think is important to think through, and what we can do differently to ensure more continuity of care. I think we are right there with you and wanting to figure that out.
So let's get back to the bill. Language that is in the bill, because that's our work, because the legislative committee is working through the language and understanding it. So I'm on page 7. This is the crux of the bill, which is an MOU, Memorandum of Understanding.
Sorry, what page, Chair?
7. That's the crux of the bill, which is an MOU, Memorandum of Understanding. If you go to, it deletes a lot of current language, which says if a person's currently receiving medication for an opioid use prior to entering a facility, they would continue they would continue that when they are incarcerated. That is struck. What the new language is saying, that there would be an MOU established with each treatment program that's nearest the correctional facility. So there would be multiple MOUs, not just one, I'm assuming. Is that correct?
That's how I read it as well.
And who would be partners in that MOU? DOC is going to execute it, but doesn't that MOU have to be between WellPath and that hub, or is it between DOC and the hub?
So
And would you be able to do an MOU with a hub? Would hubs be able to enter into an MOU with DOC or WellPath? Those are the questions that we need to have answers to.
And I think, and I'm glad legislative council is here. I think just as the department that's moving for the executive branch, I think there are also perhaps more heady philosophical questions around some separation of powers issues. As it relates to the legislature asking the executive branch to administer the department in certain ways, to enter into MOUs, to apply for grants. I think there's some of that sprinkled throughout this bill that I think, want to speak to our legislative council about, but I think the department does have some questions about the degree to which the bill reaches into the functioning of the department and its operation.
You need to present that to us. Can you have some folks from DOC present that to us? So that we can we can balance this one way or the other? We can talk philosophical really well. We got words on a page that we have to work through. And we have to interpret that language and see how it works through. So can hubs enter into an MOU with DOC or with WellPath or any private provider that DOC contracts with? That's a fundamental question to the bill. I don't have an answer to that. Can we do it? Can hubs do it? Who do we get in here to ask that?
I do think this tries to go back to the 2018 precedent. That precedent is in. I'm gonna have to look for it now, but I think this tries to return us to some intention that and before I was here, right? But those MOUs were part of the 2018 legislation, and I want to find it. It's going to take me a while. I wasn't.
If we had MOUs back then for the hubs,
I thought we had MOUs with, and this is not my wheelhouse.
Yeah, I gotta find it now
I'm
too.
pretty certain that we already have MOUs with our hubs to provide the OTP, provide methadone.
but is that for the methadone and how you get the methadone to the facility or vice versa? Because the issue at the time when we were doing this was that if they were on methadone, it had to be stored. It's where you store it, who has access to it, and at the time was working to bring the person who's incarcerated to the hub, which was a real issue for security. So is the MOU to allow that methadone to be kept at the facility? This goes beyond that in terms of really working with the person. Because what it says here is that MOU would be with the nearest hub that's nearest to the facility. That's on lines 9 and 10. And then the MOU would be for the provision of services for inmates with opioid disorders. So what are those provisions of services that would be covered in the MOU? I don't have an answer. I'm questioning, what is the provision of services, which would also include medication for opioid use disorder, but what other provisions of services, and who would provide that provision of services? Is it WellPath or is it the hub?
Those seem like really important questions, and I don't know the answer to the MOU question. I imagine that we theoretically could develop MOUs that say whatever they needed to say, I think what the questions raise for me is that it complicates the picture of who's involved in providing somebody's care. So currently that exists, for the small group of people on methadone, there is this other entity involved in their care because there has to be, because we can't do that work. But for everybody else, the majority of people on MAT who are on, buprenorphine-based medication, that's all in-house and it's integrated with their other health services. And I would say we have a lot more control over it. And so what I would worry about as DOC is that even if, yes, legally we could do an MOU, that we actually lose control. Right now, we could tell WellPath what to do. We pay them. They respond to us. If we were instead relying on services through an MOU, we lose, I think, an amount of leverage over those services because we're relying on a partner to provide them. If they say, you didn't give us access or we don't have staffing, I think we would have less leverage than we currently have with the kind of direct contract with WellPath for all of it. I think it also introduces more question about, to your point, Chair, what does WellPath do versus what does this community-based provider do as outlined in the MOU? And I think it could just get messier if things aren't going well to say who's accountable and who's responsible for not meeting certain expectations if there's more parties involved in the mix.
I have the 2018 language here, and it's a may, it's not a shall. This is S-166. It's by both House and Senate 2018. I don't remember what act it was. I just have the bill in front of me. On or before December 31, 2018, the Department of Corrections and of Health, so both, may enter into a memorandum of understanding with opioid treatment programs throughout the state, certified and accredited pursuant to level. So there was nothing in there that required it. It was a may.
And I'm pretty sure it was how you get the methadone, because that was the real issue.
Yeah, there's a
At the
chain of
time.
custody.
Mhm.
There's a chain of custody of the methadone required by the DEA.
So the language here goes way beyond
It
methadone.
does.
Language here is shall execute with an opioid treatment program that's nearest to the facility. So you're talking about 6 MOUs,
So probably.
probably. For the provision of services to inmates with opioid use disorder. So it's much more than methadone.
The reason I brought up methadone was as a case example of the challenges we have right now when we have to go outside the walls of the facility for the dosing, and that we don't adjust dosing, for example, so it needs a different dose. There's a barrier of having to go outside the walls for that dose. So understood, and that's my concern by increasing the amount we have to go outside the walls to get care. And I had some of the same questions. What does that mean, provision of services? Does this mean we can't do our own MOUD, or does it mean could we enter into that memorandum of understanding as a resource? We can consult with them. That might be welcome. But when I originally read this, I was trying to understand, does this mean we are no longer allowed to provide our own MOUD services? And I don't know that it says that or not. It's how I initially read it.
I
Don't know.
think that's why we're gonna take testimony, figure that out.
I would have, my biggest reservation with the bill is if we were no longer allowed to provide MOUD services as part of a general primary care that we provide. That would be my biggest reservation about the bill.
So does DOC have any recommended language to submit to us?
I think perhaps the first step would be changing some of those shalls to mays. I mean, we can do go through line by line if we would like to pick up on the board. I mean, I think there are still some fundamental questions that we haven't gotten to, around the budgetary impact of the bill. I know that another piece that we wanted to highlight is the use of inmate rather than offender, which is something we went through at length last year. I know that was an intentional decision, and again, really honor the spirit of the bill, but just some of the operational impacts of trying to provide medication to a detainee when they're released from custody at court. And this bill, again, would instruct us to do that, basically provide medication to someone who's no longer in our custody. So just thinking about how this might play out. I think also page 13, just questions around some of the reporting, reporting on individuals, the recidivism rates for those with MOUD, reporting on cost savings related to recidivism for those who are out in the community. I think those are their outcomes for individuals in the community. Those are just far beyond the jurisdiction of the department. Maybe the Department of Health or DEVA could help us in that work. But those are things that should give you pause as a member of the department. And then, of course, section 5, which is also 15, about, again, that the department shall seek and apply for federal, if they exist, grants and state grants. I think, again, that raises most questions about directing some of the operations of the department that I bring a lot of.
And Isaac, if you don't mind, if I can.
Go ahead.
So when you say that, Isaac, what is that like
That last piece of
that you just said? Yeah,
Yeah,
like
it-
that you're having to do something that.
No, I think it's a
Explain
fine
that.
line, right? I think the Supreme Court precedent is a little mixed on this because there are functions of government, right, that are fulfilled, not clearly always in a single branch, but Title III, the governor of the state, the administration, so execute the laws. We administer the system, the laws that are set out by the legislature. And I think we start to get into some, I think, gray territory of when the legislature is dictating how those laws are carried out and administered. In short. But I don't want to overstep ledge council or.
And I'm just trying to understand that because if you do the MOUs, what section 5, you're looking at section 5, right, on page 15?
That is on the grants piece.
Which part are you looking?
I'm looking at line 15 on page 15.
Okay, so that's the grants. So what you're saying is that we're asking you to do the MOUs. And you do the MOUs, but the legislature is telling you to apply for grants to support those MOUs, when you might want to do something different to support those MOUs.
Right. And I think, legislative intent language would be really appropriate. Like we encourage the department or the department may, but I think when you start using shall and speaking to some of those really, I would say, pretty detailed operational executive functions, I think that raises some potential legal questions.
So it's really a separation of powers between the branches.
But ledge council, sorry.
I mean, you're flagging that, doesn't
Just
mean,
I'm just saying as a member of the executive branch.
you're
gives me
just,
a moment of
for the
pause.
committee, the person is flagging that, and we can vet that with our legislative council, but it's really important, however you're keeping track of this on paper or electronically, to make sure you have flagged this so that we go back to it as a committee. Right?
Requiring us to apply for grants also highlights the question of if we don't get grants, how is something paid for? So exactly what service is being required? If it's not funded, then we're sort of saying this is something we're going to try to do to the best of our ability to fund it that is unknown. And so just to kind of add that piece back in, that's a different question than the separation of powers question.
If the grants even exist.
Right, if they don't, then what do we do?
And that's what you were talking about before. I said that there's real budgetary implications to this. And then offender versus inmate, because there is issues around the detainee population. What other flags does the administration have on this?
Just a thought or question going back to the first point of the MOUs in general. And sort of some of our concerns with the initial language, excuse me, I think on page 7. I'm wondering if, inviting us to do these MOUs with the community-based treatment providers makes more sense if we do focus on the continuity of care piece and kind of change the language so that it less describes the provision of services while someone is in custody. So that, we are explicitly kind of deepening the commitment to making sure that we have that continuity of care through, in this case, at least 6 MOUs that would spell out kind of how DOC, whoever the medical provider is for DOC, and those community-based partners are working together when someone is transitioning from incarceration to the community. I think that would already sort of address some of our issues if we weren't talking about the MOUs governing provision of services while someone was in our care.
How would that look like? Language wise?
Yeah.
With language for.
Mhm.
I also just want to point out, sorry, very quickly, that
Mhm.
we are, as you know, updating our MLUD policies, as
Yeah.
Dr. Gilliger and Viva mentioned. There's a lot kind of in play there, so just being careful not to take Django blocks out of the tower. And then also, that we are undergoing the implementation of our 1115 waiver that's going to start in less than a year, which should also help to provide reentry services with embedded case managers from the Vermont Chronic Care Initiative at each facility, which I think would maybe play into some of the MOU
Yeah, absolutely.
providing that
Yeah.
cognitive care in the community.
Yeah. I don't know, we could share more about that particular program. if People are interested.
I feel like we're just in a haze here and not having any clear direction in terms of language and how this will actually play out. And that's what we need as a committee.
I feel like we're pulling on 6 different threads. of
Yeah.
Threader and-
Yeah, it's just not coming together.
Yeah.
We need some legal counsel from your department that can answer some legal questions. Medically, you can't answer those legal questions. You're just here to provide the services. And some of this, when I read this, I'm kind of wondering too, how much beyond MOUD are we going? Because you're providing a lot more healthcare in the facilities. It's not just MOUD, it's not just reentry planning for someone on medically assisted treatment. I mean, there's folks who are under a lot of other medications that are not under the MOUD. And what do we mean for continuity of care for them as well? Right.
Isaac, can I just get a brief sort of, what do you think your timeline is for your new policies and the waiver that you said within a year, that's before next session?
Yeah, I can speak to the waiver piece and then I'll turn it over to Dave and Dr. Yu on the policy piece. The waiver should go live 1/1/2026. And we are building out the implementation plan, and I know Debo is doing a lot of work on the MMIS, which is the claims system, so that they can pause Medicaid and then restart it 90 days pre-release.
Terminated. Because now it gets terminated.
De facto termination.
Once again, I'm looking down. I thought we were trying to attempt to say what we want from WellPath, rather than telling you how to do it. And what we want is quality healthcare. I can't define that because I'm not a doctor. And continuity for a period of time after they are released. That's what I thought this bill was attempting to do. Telling you how to do it is, in my opinion, the wrong approach. To tell you to have an MOU, you may not need an MOU for things other than methodology. So that is, am I understanding what we're trying to do, Troy?
That's certainly a component of it.
Okay. So isn't it as simple as saying you are the primary responsible medical person? And we would like you to make sure there's continuity of support for a period of time. However you do it, and then we tell you how we're going to measure your performance. And that's possibly tied into a contract that if you do really well, you get more, and if you do poorly, we fire you. I mean, it seems like it's that straightforward. Am I wrong?
I mean, that's a big question.
Okay.
I'm not-
Well, no, it's your bill. It's your bill. That's why I'm asking you, if that's not your intention, to provide quality healthcare and then extended once they leave the facility.
I don't disagree with you.
And the community doctors are not involved because they don't have insurance to pay them.
Mhm.
So we're right back to WellPath
Yeah.
being the responsible entity. And we just want to make sure it continues. Right?
And I think that some of the intent is already legislated. So we are required to provide people appointments in the community post-release. We are now required when people are sentenced to provide them medication upon release for,
28 days.
depending on the medication, a certain amount of time post-release, make sure they have a prescription in the community when they get out. So we are very much working on implementing those things and lots of room for improvement and to really stand up to meet those expectations and those requirements. But some of those really are in place and we just have to catch up on our side, figure out how to do it effectively. And maybe some of it is, I don't know if Isaac's going to get me in trouble for saying this, but about sort of reporting on certain metrics to you all on a regular basis. So you understand, how we are thinking about progress against some of those existing requirements related to continuity of care. But I think the 1115 waiver is also a really big piece. And I'm wondering if it would be helpful to kind of remind people about the programmatic elements of that when we say it's starting in 2026, kind of what that will look like.
And what that catch up looks like that you just
Sure.
mentioned. That's the
Yeah.
policy thing
Yep.
that I think we started asking about.
Yeah,
And Isaac was going to defer to you on that.
yeah,
I had and it's 4 minutes before noon. So like, what does that policy roll out?
Mhm.
What are you anticipating?
Yeah.
What needs, I'm still going to have the question about what needs to be protected if we're
Yeah.
no longer using WellPath.
Yes.
Like some of
Understood.
this, I think, has to be in statute. That might not be, especially as you're envisioning policy changes,
Mhm.
departmental policy changes.
Yeah.
Yeah, I'm a little, I don't know where I am right now.
Well, I don't
Thinking
either.
about this.
And I think what would help the committee a great deal would help me as well, because I'm going through this.
Yep.
James, I'm going through this language. I've been through it a while ago, and I have a lot of questions, and I think we probably need Katie to come back in and walk us through line by line in terms of the proposed changes so we can understand. I'm just gonna use one example here. I'm looking on page 2 and 3. It's talking about medical care. This is medical care, which is beyond MOUD.
Mhm.
We have in place a process to provide medical care to inmates.
Mhm.
And on page 3, we strike out on lines 14 and 15 for pre-existing prescriptions. This is for any prescription, not MOUDs. That we strike out, what's struck here is an inmate who's admitted to a correctional facility while under the care of a medical care provider, a licensed physician, licensed PA, or licensed practice nurse, registered nurse. That's struck out. I'd like to know why. And then you go over to the next page, you're still in the same section for pre-existing prescription. This includes heart, cholesterol, blood pressure, whatever. That the new language is that you've added to this, in the case of an MOUD disorder, a provider serving the correctional facility. Can a private provider serve a correctional facility? I know that it says in accordance with the MOUD that would be executed, but can a private provider on the outside serve a correctional facility? So fundamental question I have. So the language is saying. That's a question I have. I don't have an answer. Somebody's got to provide an answer to the legislative committee, figure out the language.
One of the questions as a former community provider, I was asking is whether they can or not, and then would they? Was my other, does, and I don't know, does the legislature have the authority to say that the hubs need to be entering into these, whether the hub or other
community provider should be doing this.
Wouldn't it? For our vets, in very layman's terms, if government medical facility can't do it, they go to a private doctor.
They're not
Wouldn't
under
it be a
the,
similar,
but they're
similar
not under
model?
the custody of the state.
No, I understand, but there would be a similar kind of relationship that if the government can't provide what they need, then we go to the outside.
not-
Why wouldn't it be similar kind of
These
arrangement?
folks are sentenced. And they're under the custody of the state, so
No,
it's
I-
a different status.
So the functional part is what I'm talking about,
So
not
to answer that, what the doc said is. Like for us, so vets or whatever, so I can go somewhere else, but they don't have to serve me, so this is the same thing. They, we can say, hey, work with the hub, but we can't make the hub do it, is. Right, that's what you're trying to say, and by the way, my question was what you just said, so, but whether it's. Including regular healthcare, that's just limited to MOUD, so I didn't have, so you asked my question, so. Or had the same concerns, I guess.
It does speak to the constitutional issue that incarcerated people in America are the only individuals in the United States who have a constitutional right to healthcare. It's denying someone that care is technically a violation of the Eighth Amendment prohibition of cruel and unusual punishment because they cannot just walk down the street
Right.
and see it provided.
Right. that's Vermont Constitution or federal
That is,
Constitution.
that's I think set out in Stell v. Gamble in 1976. You can arrest it.
So precedent's already there.
And I don't want to like make matters, but I just for some clarity. When a person leaves a facility, do they need to get this treatment for the rest of their life, correct?
For MOUD?
Yes.
Potentially.
Yes, potentially. Some people do taper off in time. That's in it. It has not in the years following an incarceration, I'd say.
Okay. So it's a long-term deal.
It's a chronic condition.
It's a chronic condition.
Diabetes.
That you're taking care of it for, okay, just thank
There was, I wanted to take the opportunity. There were, Patty? Patty, I'm sorry. There are a number of questions you asked, and I don't know if I've had time to respond to all of
That's all
them,
right.
but just the OTP question is one I've asked myself, like,
Yeah.
we have an OTP, and I think I've heard lots of arguments either way, mostly against
OTP being.
an opiate treatment program within the facilities. Could we become an
Federal
OTP?
certification.
Yeah, for the federal certification. The one thing I would just, that is that would take a lot of resources, is my only skin in the game. I actually think I could think of reasons on both ends why it would be a good or not a good idea. It's just a very resource intensive thing. And I think the way the bill is written, honestly, if I understand it right, it's asking the DOC to explore and present something. I don't know. So I think it's an interesting question. It's not resource neutral violation.
Right, certainly. The reason it's there is gets back to my kind of, what do we need to codify here that's not codified in the absence of a well-running program that's currently contracted, right? That's
Yeah.
fundamentally the concern.
And maybe we as DOC can kind of, think on that and come back to you with some proposals. I think it's helpful to have the intent as clear as and distilled as that, and maybe we could take a little bit of time to answer it.
And even what should we be moving toward,
Mhm.
right?
Yeah.
So that's idealistic. The OTP is idealistic, but wouldn't it be great if on top of having the best hub and spoke system in the world,
Mhm.
your words, not mine.
Yeah, no,
It's
great.
that permeates into our correctional facility,
Yeah.
because right now I'm worried that it doesn't, due to the fact that we contract with a private provider who's not bound by
Yeah.
any sort of commitment to the hub and spoke model, right? Thankfully, they are right now. They're kind of playing nice. I'm worried. I'm worried. So I'm worried, like 10 years out, are we still providing the same quality of care
Yeah.
that we do in the community
Yeah.
within our facilities?
So if it's not inappropriate, and I know we're at it, we have the new opiate MOUD policies that we have put in place that I've spent the last year developing
partially with Andy Ranciano, and at the request of the DOC. Before Andy left, there was this, whose policies are they? Do we own them as WellPath? Or we, for rightly or wrongly or whatever? And he said, you know what, these are WellPath policies. It might make sense, and I have to make sure that I'm kind of in my rights and doing what I'm supposed to do, to share those with DOC, because honestly, and you guys have them, but to share them in a way where they can be shared, because that is the roadmap. And I think it could be a roadmap for beyond the 3 to 5, whomever is driving the bus, the roadmap for beyond 3 to 5 years from now. Not that 3 to 5 years they might need to be looked at again, but I think that's a little bit of the roadmap I hear you moving forward.
That's certainly
Part of it.
part of the intent. That is now currently in my head too, jumbled by, is this even possible? Right, that's the question I'm kind of walking away here with. And I'm not afraid of untangling things that need to be untangled. Yeah, I don't have I don't have a good closure thought.
No.
So I think we've got to go back to square one. I think what we need to do is really look at the words on the page with our legal counsel, our legislative counsel, and go through it as a committee to really understand what the bill is saying, number one. Number two, I would like DOC to go back, read the bill, please, and flag those parts of the bill that are of concern to you and submit language for that. We're going to hear from a lot more testimony, but we're going to hear from the hubs. We're going to hear from Tony Fallon. We're going to hear from folks who have participated in the MOUD program while they're incarcerated. We hopefully will hear from some medical providers out in the field. And we will put all those viewpoints into words on the page. But we need to have a starting point here with H32 and the language that's there. Some of this language may work. Some of it may need a little tweaking. Some of it may need to be thrown out and replaced with other language. That's our process as a legislative committee for that. So I'm asking you folks to go back, read the bill, go with your legal counsel, but you're going to need a legal interpretation here with you folks, and come back to us. And in the meantime, we're going to schedule again with Katie and go through the bill page by page and make sure the committee members understand the language and what it means, so that we're all on the same page with what the intent of the bill is. Does that make sense to folks?
Sure. Absolutely.
So let's call it a day today. It's after 12. It's lunchtime. Everybody's got their homework, and Katie, I really would like to chit chat with you and schedule a time. Here.